Managing high blood pressure, a scientific strategy to protect your heart, brain, and kidneys for life. Welcome to the channel Daily Health for Seniors. Treating high blood pressure is not just about taking medication to lower a number. It is a scientific process rooted in physiology, nutrition, physical activity, and even psychology. Every small change you make in your daily routine can influence your blood vessels, hormones, and heart function in ways most people never realize. In this video, we will help you truly understand how your body works and guide you in building an effective, long-term strategy to protect your heart, brain, and kidneys. Get ready for a clear, science-based explanation designed to support your health for years to come. 1. What exactly is high blood pressure and why does it matter so much? High blood pressure, or hypertension, is fundamentally a disorder of the cardiovascular system in which the pressure exerted by the circulating blood on the walls of the arteries remains chronically elevated. To understand why this matters, imagine the arterial system as a network of flexible tubes designed to accommodate rhythmic pulsations of blood generated by the heart. Under healthy conditions, the arteries dilate and contract in harmony with each heartbeat, distributing blood smoothly throughout the body. Blood pressure is measured through two key values. The systolic pressure represents the force applied to the arterial walls when the heart contracts, while the diastolic pressure reflects the resting pressure when the heart relaxes. Normal readings below 120/80 mmHg indicate a balance between cardiac output, vascular resistance, and the elasticity of the arterial system. When blood pressure increases beyond normal ranges and remains elevated for months or years, the cardiovascular system enters a state of chronic stress. Long-standing hypertension leads to a cascade of structural and functional adaptations, many of which are initially beneficial but ultimately harmful. The arteries gradually thicken and stiffen due to smooth muscle hypertrophy and collagen deposition, a process known as vascular remodeling. The heart, forced to overcome increased resistance in the blood vessels, develops left ventricular hypertrophy. Over time, these compensatory mechanisms become maladaptive, impairing blood flow to critical organs such as the brain, kidneys, and heart itself. This is why hypertension is not simply a numerical problem. Each incremental rise in pressure reflects deeper pathological shifts in hemodynamics, endothelial function, and regulatory systems like the renin, angiotensin, aldosterone system, RAS. When untreated, these changes create a fertile biological environment for heart attacks, strokes, kidney failure, and other life-threatening conditions. The common clinical classifications: elevated blood pressure, stage 1 hypertension, stage 2 hypertension, and hypertensive crisis, serve not merely as labels, but as guides for evaluating risk. Mild elevation may signal the beginning of arterial dysfunction, whereas stage 2 hypertension indicates significant vascular stress and typically requires medication. Hypertensive crisis, involving systolic values above 180 millimeters of mercury or diastolic above 120 millimeters of mercury, reflects a state in which acute organ damage can occur in minutes. Understanding hypertension as a dynamic, progressive biological process, not merely a high number, is essential to recognizing its dangers and the urgency of treatment. 2. Why hypertension is known as the silent killer. One of the most misleading aspects of hypertension is its lack of symptoms during the early and intermediate stages. The human body adapts remarkably well to gradual increases in blood pressure. Baroreceptors, specialized pressure sensors in the carotid arteries and aorta, reset to accept higher pressures as normal. As a result, the nervous system stops sending warning signals, even when the vascular system is under significant strain. This adaptive mechanism, while biologically impressive, is clinically dangerous. Most patients with moderately or even severely elevated blood pressure feel perfectly well. They continue working, exercising, eating, sleeping, and living without any sense that silent damage is occurring inside their arteries. Only when blood pressure rises abruptly or reaches extremely high levels do symptoms emerge, such as severe headaches, visual disturbances, chest discomfort, shortness of breath, or nosebleeds. By this time, vascular injury is often already underway. Symptoms of hypertension are nonspecific and overlap with many benign conditions: fatigue, stress, insomnia, or mild dizziness, making it even harder for people to associate them with a cardiovascular disorder. This explains why stroke and heart attack often occur as the first noticeable symptom of hypertension. The only reliable method to uncover the silent progression of high blood pressure is routine monitoring. Longitudinal studies show that individuals who check their blood pressure regularly are diagnosed earlier, have better long-term outcomes, and significantly reduce their risk of serious cardiovascular events. Even young adults should measure their blood pressure at least every 1 to 2 years, and more frequently if readings exceed 120/80 mmHg. Early detection is not merely preventative, it is life-saving. 3. Symptoms and the deep biological consequences of high blood pressure. Although most individuals experience no symptoms, hypertension continuously exerts mechanical stress on arteries and organs. When symptoms do arise, such as intense headaches, blurred vision, chest pain, palpitations, or confusion, they often signify acute spikes in blood pressure or the onset of target organ damage. To understand why hypertension causes such a wide range of complications, we must examine its effects at the tissue and cellular levels. Elevated pressure exposes the endothelium, the thin inner lining of blood vessels, to chronic shear stress. Over time, endothelial cells lose their ability to produce nitric oxide, a molecule essential for regulating vascular tone and preventing clot formation. This dysfunction accelerates the development of atherosclerosis, plaques of fat, cholesterol, and inflammatory cells that stiffen the arteries and may ultimately rupture. In the heart, the increased workload forces the left ventricle to grow thicker in order to maintain adequate blood flow. While initially adaptive, this hypertrophy eventually leads to impaired relaxation, reduced cardiac output, and eventually heart failure. The coronary arteries themselves become vulnerable to narrowing and occlusion, raising the risk of myocardial infarction. In the brain, fragile microvessels can burst under excessive pressure, leading to hemorrhagic stroke. Alternatively, atherosclerotic plaques can obstruct blood flow, causing ischemic stroke. Given that brain tissue is highly sensitive to oxygen deprivation, even brief interruptions can result in permanent neurological deficits. In the kidneys, hypertension damages the glomeruli, tiny filtering units critical for removing waste products. Progressive injury reduces filtration capacity, leading to chronic kidney disease and, in severe cases, the need for dialysis. Each organ system affected by hypertension illustrates a central theme. Long-term pressure overload transforms a systemic mechanical problem into multi-organ biological failure. This is why even moderately elevated blood pressure must be taken seriously. A reading such as 141/91 mmHg may seem only slightly high, yet it increases stroke risk by nearly 7-fold compared with normal blood pressure. 4. Scientific principles of hypertension management and long-term control. The management of hypertension is a multifaceted process grounded in physiology, behavioral science, and pharmacology. Its objective is not merely to reduce numerical values, but to reverse or minimize ongoing organ damage and reduce long-term morbidity and mortality. Lifestyle modification represents the foundation of treatment because it targets root causes of hypertension, such as excessive sodium intake, sedentary behavior, sympathetic overactivity, and metabolic disturbances. Weight reduction improves insulin sensitivity and reduces the mechanical load on the cardiovascular system. Regular aerobic exercise enhances endothelial function, increases nitric oxide production, lowers resting heart rate, and improves arterial elasticity. Reduced salt intake decreases plasma volume and mitigates RAS activity. Limiting alcohol consumption reduces adrenergic stimulation, while smoking cessation restores vascular tone and reduces oxidative stress. Home blood pressure monitoring provides essential longitudinal data, allowing clinicians to evaluate variability, morning surges, and the response to therapy. Studies consistently demonstrate that self-monitoring improves treatment adherence and accelerates achievement of target blood pressure. Although the general goal for many patients is below 130/80 mmHg, individualized targets are critical, particularly for older adults and those with multiple comorbidities. Diet plays an especially powerful role. The DASH, dietary approaches to stop hypertension, model, rich in potassium, calcium, magnesium, fiber, and antioxidants, directly improves vascular reactivity and reduces oxidative damage. Reducing sodium intake to below 1,500 milligrams per day, or at least lowering it by 1,000 milligrams from baseline, produces clinically meaningful reductions in systolic blood pressure. These changes require persistence, but the physiological benefits rival those of first-line medications. 5. Pharmacological treatment, mechanisms, and scientific rationale. When lifestyle strategies are insufficient, or when blood pressure rises into more dangerous ranges, pharmacological therapy becomes necessary. Each drug class addresses a specific component of blood pressure regulation. Diuretics reduce intravascular volume, lowering preload and decreasing arterial pressure. Calcium channel blockers inhibit calcium influx into smooth muscle cells, producing vasodilation and reducing peripheral resistance. ACE inhibitors and ARBs interrupt the RAS cascade, preventing angiotensin II-mediated vasoconstriction and reducing aldosterone-driven fluid retention. Because RAS contributes heavily to hypertensive vascular remodeling, these medications also provide structural vascular benefits. Combination therapy is often more effective than monotherapy, especially for stage 2 hypertension. Evidence demonstrates that combining drugs from different classes yields additive or synergistic effects while allowing lower doses of each medication, thereby reducing side effects. Modern clinical guidelines recommend early combination therapy for blood pressures exceeding 160/100 mmHg. Beta blockers, though no longer universally first-line for uncomplicated hypertension, remain indispensable in patients with coronary artery disease, heart failure, arrhythmias, hyperthyroidism, and certain neurological disorders. Their ability to decrease sympathetic drive and limit cardiac oxygen consumption makes them uniquely valuable in these contexts. Pharmacological treatment must be individualized, considering patient age, comorbidities, renal function, and tolerance. Hypertension therapy is not a fixed formula. It is a continuously evolving strategy that requires regular reassessment and adjustment. 6. Hypertension in older adults, a distinct biological challenge. Hypertension in older adults presents unique pathophysiological complexities. The arterial system undergoes progressive stiffening due to collagen accumulation and loss of elastin fibers, a process termed arteriosclerosis. As a result, systolic pressure rises disproportionately while diastolic pressure falls, producing isolated systolic hypertension, a common pattern in aging populations. This condition elevates the risk of stroke, heart failure with preserved ejection fraction, and cognitive decline. Yet treatment must be approached cautiously. Excessive lowering of systolic pressure can inadvertently reduce diastolic pressure to levels that impair coronary perfusion, especially during diastole, when the heart receives its blood supply. This phenomenon explains why older adults may become dizzy or faint when standing, a condition known as orthostatic hypotension. Falls are a significant concern, particularly during the first 4 to 6 weeks after initiating antihypertensive therapy. Hip fractures in elderly individuals carry high rates of disability and mortality. Thus, clinicians must weigh the benefits of aggressive blood pressure reduction against the risks of impaired perfusion and physical instability. Effective management requires a holistic assessment of functional status, hydration, nutrition, sleep, cognitive health, and caregiver support. Blood pressure targets for older adults must be personalized rather than universally strict. 7. Conclusion. Hypertension control as a lifelong scientific strategy. Hypertension is not merely a number or a diagnosis. It is a progressive physiological disturbance with deep roots in vascular biology, endocrine regulation, and metabolic health. Early detection, persistent lifestyle modification, structured monitoring, and evidence-based pharmacological therapy form a comprehensive scientific strategy for preventing the devastating consequences of uncontrolled blood pressure. Long-term hypertension management protects the brain from stroke, the heart from failure, the kidneys from decline, and the eyes from blindness. Small daily habits, less salt, more movement, deeper sleep, less alcohol, no smoking, constitute powerful biological interventions that reshape cardiovascular health over decades. Managing blood pressure is not the avoidance of disease. It is the active pursuit of longevity, resilience, and a healthier future. If you find the video interesting and useful, please give me a like and subscribe.